We are now on the record. The time is 12:01 p.m. The date is July 11th, 2024. This is the beginning of the deposition of Dr. Lee.
My name is Matt Powell, and I represent the plaintiff. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
I do.
Could you please tell us your name?
Roland Lee.
Dr. Lee, what is your profession? Doctor, are you licensed as a medical doctor?
Yes.
When were you first licensed?
1986.
And where do you maintain your office as a neuroradiologist?
In San Diego, California, at the University of California, San Diego, and at the Veterans Hospital in San Diego.
So you have two offices?
Yes.
Okay. What medical school are you a graduate of?
UCLA.
All right. And where did you do your intern?
It was at the Harbor General Hospital, which is a county hospital for UCLA.
And tell us about what other study or training you have in the field of medicine, neuroradiology, or even MEG.
I should start out with college, where I went to California Institute of Technology, where I majored in physics. And then I went to University of California, Berkeley, to get my master's and further studies in physics, which is relevant to MEG.
Can you tell us what MEG stands for?
Yes, MEG stands for magnetoencephalography, which measures, it's an instrument that measures the magnetic fields that your brain emits as it's thinking, basically.
Okay. And let me now bring you back after your training in physics, medical school, your internship. What is your specialty in medicine?
Radiology. And I did that at my radiology residency at the Harvard Medical School, Brigham and Women's Hospital in Boston.
How many years was that?
That was 4 years.
Okay. And could you please describe your area of medical specialty?
Okay, so radiology is the general field, and then I subspecialized after that into MRI and neuroradiology. So radiology is concerned with imaging of the human body, with all the imaging modalities and all parts of the body. My first fellowship was in Long Beach, California, at Memorial Medical Center under the man who basically developed MRI. And so it was an MRI fellowship where I used MRI to study all parts of the body, including the brain and spine, but also other parts of the body. My second fellowship was at University of California, San Francisco, specifically in neuroradiology. And that studies the brain, the spine and spinal cord, and the head and neck as a specialty. So I have two fellowships beyond my general radiology training.
And if you could you briefly explain to us what is a fellowship?
Okay, so first you start with the medical school, then you become a doctor. You have to do 1 year of internship to become a licensed doctor. After that, you have residency where you specialize in a subcategory of medicine. So that's such as obstetrics or gynecology or internal medicine or surgery, or in this case, radiology. Beyond the residency, and many people don't do anything beyond the residency, probably most people don't, but you can subspecialize beyond your residency in certain specialties. In radiology, the main specialties are, for example, neuroradiology, or you can do pediatric radiology, or nuclear medicine, and so forth. So I super specialized in first MRI, and then in neuroradiology to specialize in the brain and spine and head and neck. My two fellowships, one was in MRI, the other one's in neuroradiology, which specializes in the brain and the spine and spinal cord and the head and neck. So those are my two fellowships.
Can you tell us, in your medical school, your training, your residency, then your fellowships, how much time and concentration do you or have you spent on working with diagnosing brain problems?
It's basically my entire fellowships was involved in neuroradiology in the brain. Of course, we also cover the spine and head and neck, but the brain is a major part of neurology and neurosurgery, and so it's tremendous focus on the brain and its health and disease.
What have you done through your training and your education that you've already talked about to prepare you to be a specialist in making brain injury diagnosis?
Okay, so from the beginning of medical school, of course, all the way through residency in radiology and my fellowship in neuroradiology, injury to the brain is a very important part of my training. And then afterwards, throughout my career, of course, when I see patients' scans, brain injury is one of the most common diagnoses that I see for all imaging modalities, whether it's a CAT scan or MRI, or in this case, MEG. Also, during my professional career, as I became involved with MEG, that's my main focus in terms of clinical and research to study the disease and write papers, scientific papers about it.
Okay, I'm going to come back to that, but let me keep going with just this more foundation, and then we're going to talk about the modalities of radiology from the X-ray to the MEG and what they do. But so how many years have you focused your career on brain injury diagnosis?
Well, certainly, we'll talk about after I finish my training.
Okay, yes.
Okay, yes.
Please.
So I finished my training in, my second fellowship I finished in 1992. So since 1992, I've been practicing as a neuroradiologist that entire time.
Okay, all right. Have you ever been invited or asked to teach in the area of your specialty of neuroradiology?
Yes, basically continuously since I became, my first job I was a assistant professor at Johns Hopkins in 1992. Since then, I have basically continuously given invited lectures locally, nationally, and internationally, continuously since 1992.
Are you connected to or affiliated with, or do you have privileges with any hospitals or medical institutions or universities?
Yes, I'm currently affiliated with the University of California, San Diego, and also the Veterans Hospital in San Diego.
And have you written peer-reviewed journal articles on the subject matter of your specialty? And I know that you've written, I saw your CV, it's 58 pages long. Let's just focus on MEG.
Yes, I've written several articles about MEG and brain injury.
And have you also contributed to writing chapters of books or books themselves about neuroradiology?
Yes, I've written two books. One of them is on spinal imaging, and the second book is on MEG. And within that book, I have written chapters, including the one, on brain injury.
Is this the book that you're referring to?
Yes, sir.
Okay. Thank you very much.
Right here. Yes.
And do you by any chance hold any patents in your area of specialty of neuroradiology?
Yes, I hold 2 patents in neuroradiology in processing the MEG data.
Okay. And are you a member of any medical societies or medical associations?
Yes, I'm a member of several, the American Medical Association, the American College of Radiology, of which I'm a fellow, the American Society of Neuroradiology, and then subdivisions of that. The Western Neuroradiology Society, I've been the president of that. That's covering the neuroradiologists in the western half of the United States. There's also American Society of Spine Radiology, American Society of Functional Neuroradiology. So There's also the Radiology Society of North America. So those are the major neuroradiology societies, and I belong to those.
And I'm going to ask you to also look at these articles, and if you could briefly, without going into too much detail, describe what they are and whether you are an author of these peer-reviewed articles.
Yes. These are several articles, and I'm a co-author. Most of them I'm the senior author on, which means that my name's last because I'm the head of the group and I'm the senior author here. But just in order that you handed them to me. One is called An Automatic MEG Low-Frequency Source Imaging Approach for Detecting Injuries in Mild and Moderate Traumatic Brain Injury Patients with Blast and Non-Blast Causes.
Thank you.
That's one. So again, the title is, we use MEG and then we've automated it to eliminate bias in terms of detecting injuries in patients with concussions.
What do you mean eliminating bias?
When you look at some of the MEG data, you can look at it and you might miss something, or you might say, I'm looking for this thing, and you focus on that and you forget other things. So this way, by having writing programs for the computers to do it, you put in what you want to look for, and the program will just run itself. So it will look for what you want. It won't forget things, or won't over-concentrate on things.
Thank you.
This is an integrated imaging approach with MEG and DTI to detect mild traumatic brain injury in military and civilian patients. So here we just used MEG and another form there's a form of MRI called diffusion tensor imaging. So we used both of those to study patients with concussions.
Thank you.
Okay, here's a article entitled MEG Slow Wave Imaging for Diagnosing Non-Acute Mild Traumatic Brain Injury. And so again, as the title shows, this is sort of a review article talking about using MEG to diagnose concussions.
And you are an author,
Yes,
part of that?
yes, there's two authors and I'm the senior author.
Thank you.
This one here is a chapter called MEG in the Diagnosis of Concussion, and this was for a book on concussion from the University of Pittsburgh, and it's a survey of the field in 2014, and I'm the first author, and Dr. Huang is the second author on this paper. This is a patient, another paper. MEG slow wave detection in patients with mild traumatic brain injury and ongoing symptoms correlated with long-term neuropsychological outcome. So here's another paper where we again used MEG to study patients with concussions with ongoing symptoms, and we correlated the findings on MEG in a rough way with the long-term neuropsychological outcomes.
Thank you.
Here's another paper, again using MEG. Marked increases in resting state MEG gamma band activity in combat-related mild traumatic brain injury concussions. So this one, instead of looking at the slow waves, which we had done in the past, we're now finding that higher frequency, so-called gamma waves, are elevated in patients with concussions as well. And this one is a paper that we wrote. I'm the senior author. Single subject-based whole brain MEG slow wave imaging approach for detecting abnormalities in patients with mild traumatic brain injury. Just to clarify all these things, when we say mild traumatic brain injury, that's basically a synonym for concussions. So this is all focused on patients with concussions. And this one shows that using MEG, we can do the MEG on single patients and diagnose concussions rather than relying on a group of patients and saying this group has a different MEG findings than a normal group. Here we can say I can look at one single subject and use this to diagnose concussions.
Can you discuss the different radiological testing machines or devices that radiologists and neuroradiologists use, and discuss the specificity or what each test is good at. And we'd like you to start with like the most basic test, maybe an X-ray, and then finish with the most sensitive test.
Okay, yeah, so X-ray is the basis of radiology. It was the first one invented, and it's good for looking at different tissues, but in particular bone versus the soft tissues. So it's good for detecting fractures, like in trauma, and it's good things like chest X-rays, which is, looking for pneumonias and cancers in the chest. Now, the problem with the brain is because it's surrounded by bone. So when you do an X-ray, you basically just see the bone. You can't really see the brain inside it. So if there's a skull fracture in a trauma, for example, I can see that, but I can't really see what's going on with the brain. So this led to a very important new development called the CAT scan, computerized tomography, which basically takes cross-sectional slices of any part of the body. In particular, we're interested in the brain. So instead of just taking an X-ray of the brain and seeing only the skull around it, I can do a CAT scan and I can see the skull around it, but I can also see the brain within the skull. That was a huge revolution. So I can use that to look at the brain itself, and its particular value in the brain. It can see like strokes or infarcts. It's the same thing. Stroke is an infarct, basically. But in particular, it looks for bleeds. So I can see hemorrhage in the brain, blood in the brain, and that's good for trauma. So that's an excellent tool for acute traumatic injury, which is severe enough to cause blood in the brain. Now, for mild traumatic brain injury, though, fortunately for the patient, it's not enough to cause bleeding or fractures of the skull or bleeding in the brain. And so you don't really see much abnormal in a patient with concussion on a CAT scan. The next revolution in imaging is called MRI, magnetic resonance imaging. And again, this takes cross-sectional images, and it can see the brain itself even better than a CAT scan. And it also can see blood. But it can use, like I mentioned before, this diffusion tensor imaging. In some cases, it can also see abnormalities in, for example, the white matter of the brain, the structural integrity of the brain. So that's another way that you can look for things in concussions. But again, that's not very sensitive. So the next ways of imaging the brain are looking at the brain function. So you can use EEG, which is electroencephalography, to measure the electric fields of the brain, and neurologists all use this. Or you can use magnetic encephalography, MEG, to look at the magnetic fields of the brain. And this is different because it looks at the way the brain is functioning and not just the brain as a piece of meat. The other imaging studies like MRI or CAT scan look at the brain as a piece of meat within your skull, but it doesn't necessarily see how your brain is functioning. Now, MRI has something called functional MRI, which I can look for the blood flow in the brain. So it's not looking at the brain as it's working, but it is looking at the blood flow to the brain. But again, that's not great for studying brain function. So the way the brain works is really through electromagnetic activity. There's also chemicals involved in the brain that mediate this, but basically the brain is basically an electromagnetic organ where electrical currents are going back and forth and creating electric and magnetic fields. So really the only way to study the brain function, a major way, is to look at the electric and magnetic signatures of the brain as you're thinking or just relaxing or whatever. So MEG, what it does is it measures the magnetic fields of the brain as you're either relaxing and doing nothing, just looking at the native rhythms of the brain, or you can ask the patient to do things like think of words. Then it can measure your brain function that way. So again, the MEG and the EEG can study the brain function, and like I said, there's two major ways of doing it: the intrinsic rhythms of the brain, or what's called evoked potentials by asking the person to do something like look at something or hear a sound and see how the brain is reacting. So in particular what we found, and again, I didn't invent this. This has been known for 100 years with EEG. EEG has known that there are certain normal brain rhythms. And you might have heard of alpha waves. That's a good, normal, strong brain rhythm. What they've also said, and that goes at a certain rhythms happen in what's called frequencies. So you can have normal rhythms. Alpha is like 8 to 12 cycles per second. You can find normal brain activity also goes at higher frequencies than that. It can go from 13 to higher, which is called beta rhythms. You can also get gamma rhythms, which is higher than 30 to 40 hertz cycles per second. But we also know of slower rhythms, and those are not normal. So you can get from 1 to 4 cycles per second. That's called delta waves, and that's quite abnormal in a awake alert adult. You can't get that when you're sleeping, but normally when you're awake, you should not have slow waves. And this was not invented by me, but for 100 years, people with EEG have known this. When we do MEG, MEG has been around since the 70s and 80s, we find we can see the same things but more sensitively. And so that's why we have focused on using MEG, because I can more sensitively detect the slow waves than EEG. Also, I can localize where the slow waves are happening in the brain, and EEG is not very good at localization. So that's why we focused on MEG, to see detect slow waves. And so once you do that, we just know that's not normal. And this is not a surprise, or it's not new information. This has been known for 100 years. EEG is very common because it's inexpensive and it's good. And so every hospital in the country measures slow waves every day as a diagnosis of abnormal brain function. So now for the MEG, I can even more sensitively pick it up, and I can quantitate it, and I can ask a computer to analyze the data, which is what we've done in our publications. So I can take a person who's had a concussion and then measure the slow waves quantitatively, and also see where in the brain the slow waves. And that, without a doubt, is established as saying that patient's brain function is not normal.
Thank you, Doctor. I think most people are familiar with how a patient undergoes an MRI. Could you briefly explain how the MEG test is performed and what the patient does and how you prepare them for the exam? Yes.
So first of all, just the tests are very different. MRI, you take the patient, you put them in that, lie them down in a machine, which is basically a very strong magnet. And the magnet affects the tissues in your brain, and then you put in other waves, microwaves, radio frequency waves, to basically, you're looking basically at what's called protons in your brain with the MRI. Using this other magnetic radiation, you can flip the protons around, you can measure how they respond over time, and that's how you actually can get a picture of the tissues. But you're putting the patient in a very strong magnetic field and putting other radiation on the patient. But again, all this is done just to obtain a picture of the brain, which is a good picture. MEG is completely different. It does not create a picture of the brain itself. It's measuring the brain function. And so by doing that, I don't put any radiation of any type on the person or their brain. I'm just sitting quietly in a room. You can lie down or you can sit up quietly, and I put this helmet over your head. Inside the helmet are sensors that measure your brain's magnetic activity. So it's completely safe, and we're not doing anything to disturb the brain itself. We're just having you in a helmet and just quietly watch the brain as it's doing its thing. And I'm looking at the brain function, not the structure. So in order to know what your brain looks like, we always do an MRI beforehand to see a picture of the brain, and then I can take the picture of that brain itself, and then because I can localize the activity on the MEG, I can put little dots in the brain as it's happening. So I can see activity of the brain in real time, measured by the MEG, superimposed on what your actual brain tissue is. So I can see the activity of the brain. Now, for evoked responses, we basically have the patient just sit up. We want you awake and alert. So you're sitting in a chair in a room with light in it, but there's no pictures that you're looking at. You're just sitting. We actually have a little TV screen in front of you. Put a little green dot in the middle, and just say, just look at the screen and just relax. And what we're doing is we're measuring your brain's normal rhythms at that time. And as an awake, alert, adult, you should not have slow waves. And then we just do that for 5-minute segments with your eyes open and eyes closed, and just measure your brain rhythms. And then we can put that through the computer, then analyze your brain's rhythms. And as a normal person, you will find very little slow waves. But if you've had a concussion or other diseases, you will have abnormal slow waves, and we can quantitate how much slow waves there are and where they are. And we can also do mathematics, statistics, to prove that what you have is more than what normal patients have. So we've measured over 100 normal patients of various ages, and we know how much slow waves there are, and the answer is very, very little. And then we can measure patients who have concussions, and we measure the amount of slow waves, and mathematically we can prove that it's more than what a normal person has. And then we can also plot where in the brain those abnormal slow waves are occurring.
Thank you, Doctor. Can you just help us understand a little physics, how a magnetic wave, what's the speed of magnetism? And
Well, electromagnetism is the speed of light. So that happens basically instantaneously. The speed of light is 186,000 miles per second. So basically, from traveling from your brain to the sensor, it takes basically zero time. And so as your brain is working, instantaneously, we can see what's happening. So we measure it like every 1,000th to 100th of a second. We're measuring your brain activity, and that's basically in real time, because electromagnetism is basically instantaneous.
And what causes a magnetic wave to come out of the brain? Is it the synapse between the cells that you're measuring?
Yes, basically you have currents that are, the brain cells are, it's a cell body, it's a round, very small round blob with arms coming out. And these arms will attach, will come very close to touching many other brain neurons. You have, billions of these in your brain, and they're all talking to each other with these, across the synapse. We have the dendrites and the axons. The dendrite is the going out from the body, axons receiving into the body, and there's a little gap there. And so we can see the electric current as it travels down the dendrites to the other neurons, and we can measure the activity. We can't measure from one particular one, but the way the brain works, you have 100,000 of them or so organized in columns, and we can see that. We can measure that. So we're measuring the electric current. The electric current, as it passes, creates a magnetic field. So you may know from school that when I have a current passing down a wire, you can put a magnet around it, and you can measure, or like a compass needle, you can measure the magnetic field around a wire. That's basically what we're measuring. We're measuring the magnetic field instantaneously with the currents that are how your brain works. So your brain's sending currents to all these other different parts of the brain. I can measure the magnetic fields generated by the currents. When I have these sensors embedded in the helmet, they're measuring the magnetic field, millisecond by millisecond. I'm seeing that's what's happening. And then I can calculate where in the brain that's happening, by taking all the data from the sensors and then analyzing it. I can tell where in the brain it's happening at any given point in time.
Can you talk about how scientifically reliable the collection of the data is when you're performing the MEG?
It's completely reliable. MEG's been around, and EEG before it has. EEG's been present for 100 years. MEG has been present since the 1980s, and we've gotten whole pictures of the brain since the 90s. So places across the country, there's a few different manufacturers of these machines, and when we do the measurements, everybody gets the same answers, and it confirms what we know from 100 years of EEG. We know, for example, the alpha waves are strongest in the back of your head, and when your eyes are closed, and it goes away when the eyes are open. That's confirmed with the MEG. But all the different tests that we are done with EEG are confirmed with MEG, but just more sensitively.
So is there some sort of scientific calibration or agreement among neuroradiologists as to the frequencies or the speeds or the collection of data?
Yes, absolutely. Again, we've basically just piggybacked off the 100 years of EEG experience, so we know the frequency bands are confirmed for every neurologist. Every physician knows about the alpha waves, 8 to 12 hertz. They know about the gamma waves, which are higher frequencies, 30 and up, so forth. Then the delta waves, we all know that delta waves from 1 to 4 hertz are abnormal. So there's universal agreement on delta waves. There's also universal agreement that delta waves are abnormal, and that's proven every day in all the hospitals of the country. And the few hospitals, all the 20 that have MEG, we confirm it every day as well. So this is known science.
And doctor, have other neuroradiologists or physicians or medical schools performed analysis to look for false positives and or false negatives? In other words, where the test isn't accurate? If you could tell us about how reliable is the test so that we don't have false positives or false negatives?
Yes, I think, again, going back to 100 years of EEG, it's for an awake alert adult, you basically don't have gamma waves. Delta waves. The slow waves are just abnormal, and that's very well established. With MEG, because we're more sensitive, we can find very small amounts of delta waves, but in our publications, we have shown the way we've published our papers, the way we decide to say if somebody is abnormal or not, is we have a database of what normal is, which shows, of course, a lot of alpha waves, because everybody has that normally, and very little delta waves. We can measure how much that is, and you can do statistics and show what a normal range of delta waves, which is very, very low. And then you can do statistics like we did, where we go like 2.5 standard deviations above that, and say anything above that is abnormal. Now with that a cutoff, we've purposely cut off so we got no false positives on our in our normals.
Can you explain to the jury what you mean we cut off all false positives? What is a false positive and why is it important to cut them out?
Okay, so when you do any kind of measurements, let's say like a temperature, we know temperature is a pretty good analogy for the MEG slow waves. So we know, you've learned in school, normal temperature is said to be 98.6, and a normal human being, 98.6 is normal. And you also know that when you're sick, you run a fever. Now, not everybody who's sick has a fever, but it's a very good sign. And so, again, well, it's 98.7 abnormal. Well, doctors don't use that. So they would like to go standard deviations above. So doctors will usually say 100.3 is abnormal. So what you want to do, though, is you want to establish a number where when you get that number, you know that's not normal. So I think from your own experience, you know that you measure your own temperature. It might be 98.6, it might be 97. But also, you know that if it's 100.3, and that's what doctors use, it's not normal. So that's by having a cutoff of 100.3, and again, often you'll get temperatures of your own. If you measure yourself or your kids, you'll get 100 at 2. That's just not normal, okay? You know that. It's just far out of the range of what normal is. Now, but 98.7, 98.9, something like that, may or may not be normal or not. So that's why they established a cutoff that's well above what normal range is. And that's what we've done with MEG. There's very, very little slow waves, but we establish a cutoff of slow wave energy that's far above that. So when we see that, we might be missing some people who do have concussions, so we might call it abnormal. So we'll pick up 85% of the concussions. So we're willing to miss 50% of people who have concussions. We might miss it, but we do that so we basically never will call it normal abnormal.
Did you say you're willing to miss 15%?
Yes.
Okay, so there could be some false negatives. In other words, we don't diagnose a concussion in 15%, but we never make a mistake and say someone who doesn't have a concussion has one?
Exactly correct.
Okay, all right. Thank you. All right, let me move now did you have a patient by the name of Paul Jones in which you had an MEG study done?
Yes.
Was it done with the same scientific principles and methods that you've described that you use with all your patients?
Yes.
Okay. Before we jump into it, can you just give us the roadmap, the overview? What was the findings of the MEG of Mr. Jones's brain?
Okay. We did find that his brain function on MEG was not normal.
Okay. If you would now, could we ask you to look at your report and walk us through the report and show us what your findings were and how you did it? Doctor, is this your report?
Yes, this is the MEG. There's also a written report, but basically gives more background in the written report, which you have there. But this is the images that go with the report.
Okay, good. And if you could tell us a little bit about the report. You don't have to read the whole thing, but just summarize it for the jury. They'll have an opportunity to read this in the later in the courtroom.
Okay, so what we do is, again, as we've described, we have the patient sitting up in the MEG suite. There's a helmet that's placed on his head. There's lights in the room, so he can see and he doesn't have sleep. And he's been counseled to get a good night's sleep, so he's rested. And then that's a good way to get the resting activity of the brain. So he's sitting in a chair, and in the room, there's a little screen in front of him. There's a screen in front of him with a little green dot. You say, just look at the dot, and just relaxed. And then for a few minutes, we'll say, close your eyes. We'll measure the brain activity. The eyes are closed. Same thing, the eyes are open, and we do that for about half an hour. And then we can then measure how much slow waves versus alpha waves, delta, gamma, all those energies, and we can measure that and then compare it to what normal is.
And how did Mr. Jones' brain perform on the MEG?
Okay, so he had multiple regions of abnormal slow waves. And so as I mentioned, you have to do an MRI first. So he had an MRI at another place, and then we can take that MRI of the brain, the pictures of the brain, and we can show where in the brain the regions of slow waves occurred. And so, yeah, you can see my arrow here. So here's the brain, and we have the brain sliced in different planes. So this is, you can tell, it's slicing the brain from the side. Okay, sideways, you can see here's his nose and his eyes, and the brain's here. Here it's coronally, so as he's facing you, we take slices like this, and so you can see where right behind his eyeballs is here. And then we take it like slicing a loaf of bread from the top. So this one is called axial, slicing the brain like this. So we have 3 different planes that you can slice the brain in, and from that we can therefore localize in space in the brain where this activity is. So we're just pointing out different regions of here, colored with yellow, of abnormal brain slow waves. And again, a normal adult, basically, you just wouldn't have any regions of slow waves. We do this, and there's no regions that would show up as yellow because the brain would not have the abnormal slow waves in a normal person, a patient whose brain is functioning normally. So these regions, and these are just names of where this is. So the one here where the crosshairs is, it's basically, it actually covers multiple regions, but it's the prefrontal cortex, ventromedially, bilaterally, it's both right and left. The cingulate gyri also are parts of the brain that go like this, and so here's the anterior part of the cingulate gyrus is what this also refers to as well. And subcallosal, because here's what's called the corpus callosum, this thing here, it's below that, so it's also called subcallosal cortex, which that's also the anterior part of the cingulate gyrus. So that part of the brain right here has abnormal slow waves. Here's another set of sagittal, coronal, and axial images, and the crosshairs are going to a portion of the brain which is called the insula on the left side here. There's also the Heschel's gyrus, where hearing is in this vicinity, and there's also the operculum, is the part of the brain overlying the insula. So the insula is here, the operculum is overlying it. So again, this part has slow waves here. we can see that there's a green arrow right here, and that points to, it's called the fusiform gyrus in the temporal lobe. So temporal lobe is here. You see temporal lobe, this is temporal lobe. Off to the sides, here's the frontal lobe, sort of in the front. And here, so this is a temporal lobe. So the temporal fusiform cortex is here. Then right here, with the blue arrow here, we can see that this is sort of the front of the head. And you can see if this is the front of your head, your eyes are going to be under here, okay? So that's called the frontal orbital cortex, because it's the frontal lobe on top of where the orbits, the eyes are. So the frontal orbital cortex, and again, the singular gyrus comes across like in that arc from here to here. So it's also the singular gyrus as well. So this is just another part of the brain with abnormal activity. This is that part that we talked about before, the operculum over the insula, so like we showed in the previous slide. So we're just showing these different regions of abnormal slow waves on different slices of the brain. And then this one also, this is the right side here. So sort of, this is the right side, here's the left side. So we have the crosshairs. This is the right superior and middle temporal gyrus. This is, again, portions of the right temporal lobe right here. Again, temporal lobe off the side, frontal lobes over here, frontal lobes here, temporal lobes here. And so the crosshairs is in the temporal lobes. And then the pink arrow here also goes to like the right-sided insular cortex, and also something called the globus pallidus right here. So
is this view we're looking at where it's axial and that Mr. Smith's eyeballs are looking kind of upward?
Exactly. So here we can see this is sliced like this, and we can see here's his right eyeball and his right eye and left eye. It's just above the eyeballs, but this is where your orbits are. Your eyeballs live in a place called the orbits. And so we can see the top of the orbits right here. If we went down a little bit lower, we could see the eyeballs themselves.
And when you use the green crosshairs on one image, like the upper left-hand picture, that corresponds to the same spot that's in the picture next to it and below?
Exactly. The crosshairs are in three-dimensional space, so I can see it in the coronal plane and the sagittal plane and the axial plane, and that uniquely identifies that point in space. And so I'm focusing on that region of activity in those three planes. And again, we can see the temporal lobe. The temporal lobe is off to the side, and here it is. You can see it's off to the side here, and it's off to the right side. And here it is coming from the side, a side view. It's off to the side here. So this is in the right temporal lobe, and it's between the superior and middle temporal lobe gyri right here. So here's the superior and the middle. So it's between the superior and the middle temporal lobe gyri in this three planes in space on the right side of the brain.
Okay, thank you.
And then, there's another one right here, which is sort of in the midline, but this is at the back of the head near, okay? So the left lingual gyrus, this is called the occipital lobes, where vision is seen. And so I can see in three planes, it's right sort of in just the left of the midline in the occipital lobe. Just another region where there's abnormal slow waves. And then the last picture is a little different. So what we do here, after we've looked for slow waves while the patient is relaxed but awake and alert, then I want to confirm that vision is correct. So what I do is a little bit different. Before, the patient is letting his brain do its thing as he's just sitting there. Here I'm doing something different. This last picture, what I do is we put electrodes on his wrists, the little wires on his wrists, and we give a little shock, the right wrist, left, left, right, and we shock it. So when you shock something or you touch something in the body, the brain senses that. So after I shock that wrist, there's a portion of the brain that's activated that says, oh, you're shocking me. And so when I shock the right wrist, the left brain is activated. When I shock the left wrist, the right brain is activated. So what I'm doing is we can see the brain electromagnetic activity showing up, shock, 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 and I can see that as it's happening. Now, why do I do this? It's because it's very well known to every doctor and every person who studies the brain, exactly when you do that, we know exactly where that happens on the brain. So if I look at anybody's brain, a picture of anybody's brain, and I say, I shock your wrist, every neurosurgeon or neuroradiologist should be able to point and say, well, I know exactly where that activity will happen. And it turns out that activity will happen on the, there's a special groove in the brain called the central sulcus. That's here, and it's here, okay? And we all know from many years of surgery that when you shock the wrist, there's a point on the front of that central sulcus that will be activated. That's your sensation. And, but what this is doing is I'm actually measuring it to show, is that correct? And indeed, when I shock the wrist, amazing, it's actually quite amazing when you figure out where that activity is in the brain. It's right here on the anterior bank of the central sulcus, and it's exactly where we all learned in medical school. But I can see it now. So what this does, it proves to me that when I say that the subcallosal cortex was involved before, that's correct, because here I've excited a piece of the brain where I know it has to go, and it went exactly there. There's no adjustable parameters. You can't fudge something. It's like it has to go to one place, and it goes exactly where it should. That way I know that all the other places where I've looked at, that's a true spot, because when I chose a spot, I shocked the spot where I know it's going to show up. It did. That means all these other spots where it shows up, those really are valid points.
So this is like a form of calibration?
Exactly. That's the way I calibrate and confirm that my localizations are correct. When I fuse the brain MRI with the MEG, this is 100% correct.
Okay. Doctor, does that complete your report of Mr. Jones?
Yes, just basically showing the calibration is the localization is accurate, and then showing there's multiple regions of abnormal slow waves in this guy's brain.
Very good. All right. And what was your diagnosis or reading as the interpreting radiologist of Mr. Jones' MEG test?
The reading is that the brain function is abnormal due to the presence of multiple regions of abnormal slow waves in his resting state, but when he's awake, that the presence of these abnormal slow waves proves there's something abnormal about his brain function. You should not have these slow waves if your brain is functioning normally.
And is this MEG test that you did on Mr. Jones an objective test?
Yes, it is, because you can't fake your brain waves. So a lot of tests, most of them done are saying you have to test the patient. Say, do you remember who the president is? Do you remember what day it is, and so forth? And those tests are very important. I'm not disparaging them. They're very important. They're critical to do all the testing. You have to ask the patient, how do you feel? And then you might ask them to do simple tests like do arithmetic and so forth. Those are critical to be done, all right? But the fact is that a patient may fake it. The patient may say, no, I don't know who the president is. I don't know what day it is. I don't know anything. Or, what's your name? Oh, I forget. I mean, you hope they don't do that, but you can't really tell if they're faking it or not. Whereas you can't fake your slow waves. Just like I can't fake my temperature. Like your child might say, I'm feeling lousy, I'm feeling sick. Okay, he might be. He probably is. But again, if you put a temperature in his mouth, he's 102. You can't fake that. So there's something objectively wrong that you can't fake. And same thing with these brain waves, that you can't make these regions come up by thinking about it.
Let me switch gears and talk about it. You talk about these brain waves and slow brain waves. Can you explain that a little more precisely, like why there's certain areas of the brain that have these different waves? And what do you mean by slow waves?
Okay, again, when we talk about the brain waves, everybody has, your brain's working if you're awake and alert. And so there's different, it's called frequencies. So you actually measure it, like if you sing a song, you go, oh, that's a low frequency, that's a high frequency. You actually measure the frequencies of things. Okay, so similarly in my brain, I can measure. So your brain is actually giving off these waves. You're giving off magnetic fields. So this sensor is picking up all the magnetic activity your brain is giving off. And so I can, again, with these sensors, I can measure if they're low frequency or high frequency. Just like if a microphone, I can measure frequencies of your brain. Like it might be a low or high, and you can measure it go ooh, it can be measuring all different frequencies at all different times. Your brain is doing that right now. It's just that I can't hear or see these brain waves. That's why you have a detector that can do that. So what the thought is that when your brain is getting all the normal inputs from everywhere else, it's happy and it's singing at higher frequencies like alpha waves, it's higher wave frequencies. But if you cut off the response from all the other ones, it's not saying, oh wait, I'm not hearing the input from all these other parts of the brain. I'm not happy. That's what generates slow waves. So it's proven by actually taking brains and cutting them that by damaging the brain, they're not getting the inputs, and that's when it brings up this abnormal rhythm. But if it's getting inputs from everything else, it's happy, and so it's singing at a higher rate. Only when you disconnect it or damage it or something like that, it's not feeling the normal stuff it likes to, then it uncovers an abnormal low frequency.
And based upon your training experience, the testing you did on Mr. Jones, can you just summarize what are Mr. Jones's brain condition based upon your review of the MEG study?
Okay, it's abnormal again. Because I'm seeing slow waves, it's abnormal. That's evidence of objectively something is wrong with his brain function.
Okay.
Now, although, our paper stuff, we have just said in some ways you can tell if it's slow waves here, then we have these symptoms. But, the problem is the brain is very complicated. So many parts of the brain are connected to many other parts. So just because I injure one part of the brain doesn't mean, or I see slow waves from one part of the brain, does not mean, well, that's for sure going to predict some kind of clinical deficit. So I'm not using to say, well, because of this, that's why you're mad all the time. I can't do that. All I can do is say, something is wrong with your brain.
And as a radiologist, do you defer that clinical correlation in that context to the treating physicians that order the test?
Yes.
Okay. Does the pattern that you've seen in Mr. Jones, is that similar to the pattern you see in your other patients, specifically the veterans that have suffered concussion injuries? Is it the same type of results when you run the MEG?
Yes. They all have abnormal slow waves. And again, the locations can be different because it depends on where you get your head and so forth. Now, fortunately for all these, like I said, because concussions are milder than like severe injury, like if you have somebody sledgehammer your head, I don't need to do MEG. If an MRI, or a CAT scan, you can see the brain is destroyed there. Luckily, that's not the case here. The brain is not physically damaged that you can see by looking at a picture of it. So depending on where the injury is, if it's mild, I won't see it on MRI, but I will see slow waves. But yes, it may depend on where the patient gets his brain injured. The slow waves might be different places. But the concept is it's abnormal slow waves and the patient is symptomatic.
All right. And doctor, the opinions that you've expressed today regarding Mr. Jones, are they based upon science and evidence?
Yes.
And all of your opinions within a reasonable degree of neuroradiologist certainty?
Yes.
Okay, and within a reasonable degree of medical certainty?
Yes.